And so let's get now to the topic of the New England Journal perspective you wrote, and it was essentially that you've already done a pilot ACO here. So could you go over that, please? It was called the acronym PACE. What was that?
Well, the PACE program is only a small program. So the PACE program was a program for Medicare and Medicaid eligible patients, about 150 elderly patients who were very frail health. And we really took those patients and we did things that we don't normally do. That is, we pick the patients up at their home, we bring them to the outpatient setting. There's a nurse practitioner that goes over their health needs. They get to interact with other patients. Their medications are controlled. We make sure that they're in a rehab program if that's what they need. All of the things that go on with these patients. Then we make sure they get back home, and we're continuously following up on these patients. Now that's a very small program, but it has prevented those patients from either being in nursing homes or getting admitted to the hospitals. So that's one piece of an ACO.
What outcome data do you have to show in terms of better care or lower costs?
Lower costs, we saved about $100,000 on the program. Patients don't get admitted to the hospital and they don't live in a nursing home environment. The second part of the HMO probably is much bigger. That is, we have about 280,000 people that are either in Medicaid or U.S. Family Health Plan. That is a totally capitated program where we take care of all their health needs. We get a payment per month per patient, and that has been profitable. Not great profitability, but we take care of all their health needs, and very importantly, satisfaction rates of those patients is very high, the highest in the state. So I think you can have great quality care, control your costs, and importantly, do things that you would not do if you were on a fee-for-service basis.
Dr. Goldschmidt, do you have any comments on that?
Well, yes, you know, what I really enjoyed about the lessons from Johns Hopkins New England Journal paper is the way Scott and Ed really insisted on the importance of preventive care. I thought that the paper was very strong relative to that critical issue. You know, the best way to perform a surgery is to not having to perform it. And that is so true for, in particular, elderly patients. Whenever you can manage a condition on the outpatient base and prevent the patient from having to be admitted because of the quality with which you prevent disorders and, for example, chronic illnesses to degrade over time. That is really the best way to manage the care and the life of patients.
You mentioned previously, Dean Miller, the getting away from the fee-for-service. So let's discuss that. Is under an ACO, would essentially doctors at academic medical centers be under a salary? I suppose that's more of the current structure of, say, the Mayo Clinic, if I'm not mistaken. Would the doctors be paid more of a flat salary as opposed to fee-for-service? How would that work?
Well, most academic healthcare centers, most physicians are on salary already. I think people have said the Mayo Clinic and the Cleveland Clinic, but as you look across the country, most physicians are salaried. Now, I will say that in most medical centers, on top of that base salary, there may be incentives for people who are more productive and also to put them more in range with you know, what a neurosurgeon might make versus what others make. But the salary structure, and I think you're going to see more and more of that, a flat salary. More and more physicians are really desirous of knowing what their salary is going to be.
And to either one of you is, how can trying, you know, it's not easy to motivate or coordinate or change behavior of an academic medical doctor. There's a variety of reasons for that. How difficult will this be to, what will it be, a financial incentive, or how will you actually make these changes be adhered to? I think that might be one of the big challenges. Is theoretically it's one thing, but to actually make it happen.
Well, I'll let Pascal go next, I guess, on this one. I think there are 2 or 3 elements that are critically important. Number one, there has to be transparency of what the organization is trying to do so that people understand the financial implications of what an accountable care organization, and the physicians and the faculty need to understand that. Number 2, I think one of the big issues has been that the clinician has never been valued, I think, as much or is perceived as valued. My view is that a very good clinician is valued, brings real value. But one of the things that the valued physician needs to be able to do is to understand and be able to teach the next generation or put programs in place that show real value. And so part of the promotion system has to value that. On the other hand, the physician that's doing it needs to show that the program they have in place about how to take care of a congestive heart failure patient or a patient with diabetes is really the best, and they can show that. And then the third is the accountable care organization needs to take the dollars that they have been able to garner because and then reinvest it within the organization so that it makes it easier for the physician to practice and more efficient for the physician to practice, and the patients get better care.
That's a good point. Right now the typical academic career model is rewarded with a number of publications, number of grants. How do we tangibly make a parameter to measure for how well a doctor is working collectively with other physicians, increasing clinical care? How do you make a measure for that?
Well, typically, Steve, academic physicians are very high achievers, and I believe that if you create a recognition of the importance of patient satisfaction and quality of care, particularly when we are responsible for people's health in the context of accountable care organization, I think that the emphasis on quality is more than ever an emphasis that will really bring fruit. Think about it. If you have an interaction with a patient that not only leads to patient satisfaction, but also to the patient really understanding what the patient can do for their own health and prevent the need for rehospitalization or another event, if you will, I think that it will have a very significant beneficial impact on also the sustainability, economic sustainability of the accountable care organization. And so we are moving, I believe, from a system where the incentive was probably biased in a direction that was not necessarily the best one to a system where the incentive is placed on really what counts, i.e. the health of the patient, the prevention of bad things to happen to a patient, and also, very importantly, the satisfaction that patients have when they encounter their care providers, both nurses and physicians. I think that it's also very important to recognize that this is not just going to be physicians that will be able to deliver the care, but nurses will play a very important role. I'd like to
So what I'm hearing from you is perhaps maybe making surveys of patient quality of care or readmission rates, those types of measurable outcomes factor more into the career path of an academic. Are you thinking in terms of that, Dean Miller?
I certainly think, as Pascal's pointed out, the electronic patient record that's going to cut across the whole organization is going to give you the ability to actually measure quality of care delivered by different physicians, and also look at the cost related to the care that's delivered. And if you can find a provider that's delivering high quality care at low cost, you would say that that's a gold standard that you would like to go after. So many of these things are interrelated when you start to think about the accountable care organization and how important IT is going to be for this.
And I suppose we can close on this is some of the negative consequences might be these ACOs might revisit the problems of the 90s where HMOs were causing hospitals to discharge patients after delivery too soon and skimping on care. How is that going to be avoided by just
Well, I think it's one of the issues that you worry about, but remember that in the HMO era of the 90s, part of what was driving it was trying to bring value to the stockholder of the company, so that it was important for the company to have profitability so that could be passed on. The accountable care organization, the profitability gets pumped back into the organization. And if the organization is doing it correctly, they are going to be investing in things that are going to make it better for their patients. So when you start to survey patients, quality of care, satisfaction that the patient has of their care, these things are all going to add together instead of trying to take the profitability and give it to a stockholder.
I think that what Ed said is so true, that you know, what has made extraordinary progress over the past 20 years since we had the issues with HMOs is the recognition of the importance of patient satisfaction as a very important marker that we need to follow. So I believe that the opportunity to really use patient satisfaction to make sure that as we distribute the resources that we have, we are maximizing the opportunity for patients to get the care that they're looking for, and therefore are satisfied customers. I think that that's going to be a very important difference between what happened in the past and what will happen today with the accountable care organizations.
Well, we could talk about this a lot more. I think the actual details from the government are supposed to come out any day now.
Correct.
And so thank you all very much. Thank you down there in Miami. Thank you, Dean Miller.
Very welcome.
Thank you.
Thank you, Ed and Steve. Thank you very much. Bye-bye.